Hi there, my name is Tom Kelly. I'm one of the clinical fellows at Sheffield Teaching Hospitals. Today I'm going to be taking you through a study that was conducted at the end of 2020, looking into the follow-up of spinal cord injury patients at the Princess Royal Spinal Injury Centre in Sheffield, which is a national centre in the UK. So as a bit of background, neurogenic bladder can be a significant source of long-term complications for patients who've suffered a spinal cord injury. Complications such as urinary tract infections or bladder/renal stones are common, with the most significant concern obviously being a deterioration in a patient's renal function. Historically, prior to the availability of regular monitoring and modern interventions, urological complications had been the most common cause of death in this cohort. NICE have produced guidance on how patients with spinal cord injury should be assessed, and also recommendations on how these patients should be followed up to reduce the risk of further morbidity. At diagnosis, they recommend a detailed clinical history be taken, a urine dip and a fluid input-output chart be conducted for a minimum of 3 days, urinary flow rates in those who maintain the ability to voluntarily void, and finally a renal ultrasound and video urodynamics for those considered to be high risk. It should be noted that every patient that's been looked at in this study would be considered high risk under those guidelines. From a surveillance perspective, NICE recommend these high-risk patients be offered lifelong imaging every 1 to 2 years as a baseline, and suggest that this frequency be tailored to suit an individual situation. So you'd increase frequency based on diagnosis and current management. They also recommend that some consideration be made to using urodynamics as an ongoing part of any surveillance regime. And whilst they suggest that EGFR and serum creatinine are not considered to be reliable indicators of changing or new pathology, it is recommended that patients have these bloods as an adjunct to the previously mentioned imaging, especially if there's any cause for concern found on that imaging. The aim of the study was to evaluate the surveillance protocol for imaging of the urinary tract for patients with various spinal cord pathologies at the Princess Royal Centre and see how well it conformed to the previously mentioned guidance. The study was designed around reviewing 10 years worth of notes and images for 40 spinal cord injury patients. Data was collected to include the period of 2009 to 2019. The 40 participants were randomly selected from that period, with the only criteria for their selection being that they had a spinal cord injury and had been cared for by Sheffield Services. Notes for each patient for the entire period were reviewed using our electronic document management system, EDMS. This included detailing symptoms, renal function, and any new or changing pathology, as well as evaluating the regularity with which surveillance had occurred. All imaging for the period was also reviewed using our picture archiving system, PACS. The results of the study are outlined in this chart. Of the 40 patients who were selected for review, 35 were followed up for the entire 10-year period. Unfortunately, 5 patients passed away over this period, and as a result of difficult to access historical data, it wasn't possible to accurately assess their cause of death, and as a result, they were excluded from our dataset. Of the remaining 35 patients, 20 were identified as having an infrapontine suprasacral pathology, whilst 15 had a sacral infrasacral pathology, including 8 who suffered from spina bifida. Various bladder management techniques were employed by the cohort at the start of the data collection period, including intermittent self-catheterization, reflex voiding, artificial urinary sphincters, or suprapubic/long-term catheters, with some relying on incontinence pads or condom sheaths. 80% of this cohort were found to have an adequate number of surveillance scans of more than 5 over the 10-year period. Initial urinary tract ultrasounds in February of 2009 identified 8% of patients in this group had existing pathologies, which was subsequently considered to be their baseline moving forward from the perspective of the study. Subsequent imaging identified 17% of the cohort who developed new pathologies that required adjustments be made to their bladder management. 14% of patients had incidental findings that required no further intervention. New pathologies identified over the period include 1 perinephric collection, 3 bilateral hydronephrosis, 1 unilateral hydronephrosis, and 1 isolated hydroureter. In summary, our sample covered a broad range of spinal pathologies utilizing various bladder management techniques based on their initial neuropathology. The vast majority of these patients had an adequate number of surveillance scans over a 10-year period, with even more having at least one. A significant proportion of this cohort developed biochemical or radiological complications that resulted in changes being made to their bladder management in the interest of optimizing their renal function and minimizing long-term morbidity caused by its deterioration. In conclusion, the review showed that an adequate surveillance protocol had been implemented at the Princess Royal for our cohort over a 10-year period. The importance of personalising the frequency of both ultrasound as well as ongoing adjustments being made to bladder management based on the nature of an individual patient's spinal cord pathology was highlighted in the interest of maintaining renal function and minimising long-term complications in these high-risk groups. Whilst adequate, an 80% surveillance rate is obviously not ideal. Based on the data collected, it's very difficult to ascertain why some scans were not conducted regularly enough for the remaining 20% of patients. Repeating this study in the future, using a larger cohort and more modern note-taking systems, would likely highlight these issues more clearly. The major difficulty when trying to ascertain the cause of these missed surveillance opportunities has been missing data caused by the transition from handwritten to electronic note-taking. A purely electronic dataset would very likely give clearer results. Thanks very much for listening. Feel free to leave a comment or question below the video and we'll get back to you as soon as we can.